Welcome, everybody. My name is Dr. Greg Vidnishkishorn, and I'm very honored to be able to be here with you today, virtually at the very least, about a new condition, a challenging condition that we have been facing around the world for the last 2.5 years. And that condition is long haul COVID. So here's my flight plan for today. And again, forgive me, I'm an aerospace medicine doctor, so I always have a lot of aviation references here, but here's what we're going to cover. So first up, I'll start with a clinical presentation about this condition. Then we'll talk about risk and prevalence, go over some biological plausibility issues, talk about our treatment here overall, and then some of the occupational challenges that this condition offers us. But before we get too far into the woods here, I'd like to give a face to this condition and start with a bit of a clinical vignette. So this is a patient that is waiting to visit with you in your clinic. And he works as an ICU nurse, and he came down with COVID-19 about 6 weeks ago. And his acute infection was fairly normal. He didn't need to go into to see his primary care doctor, certainly didn't need to go to the ER, just isolated at home. The problems really began, though, when he tried to get back to work after his isolation period. He found that he was suffering from ongoing symptoms like fatigue that would last for several days after doing minimal activity. He was having troubles thinking. He found his heart rate was going all over the place. And he was getting these weird tingling and numbness sensations in his extremities. Because of this, work had been very difficult. He was having performance issues, and this led him to be also quite anxious. And with all of that, he actually was out of work now for about 1.5 months by the time that you see him. So this is the challenge that we are seeing now on a day-to-day basis when it comes to long-haul COVID. All right, to start with meeting that challenge, let's start with some basics here. First up, what is long-haul COVID, or what we call here at Mayo Clinic post-COVID syndrome? Well, there are a few different definitions out there, but overall, long-haul COVID is a state of prolonged symptoms after an acute COVID infection. What kind of symptoms? Well, you can see here in this diagram some of the initial symptoms that were presented in the first research article that documented long-haul COVID. It goes all the way back to JAMA, Journal of American Medical Association, in August of 2020. And I've highlighted here at the very top the two most common symptoms at that time: fatigue and dyspnea. And this fits very well with what we have also seen in our own clinics here at Mayo Clinic. I have the pleasure of serving as the medical director for our COVID activity rehabilitation program, affectionately known as CARP. And what you can see here in this slide are the most common symptoms our patients in CARP have presented with. And right at the top, consistent with the first reports about long-haul COVID, are fatigue and respiratory complaints. It's important to realize that the fatigue associated with long-haul COVID is quite profound. So for example, patients will often state that they'll do something very simple, like taking the dog for a walk or taking out the trash, and then they will have fatigue that can last for hours or even days. As for the respiratory complaints, that is typically shortness of breath and cough. And this can happen with activity, but also at rest. Now, while those, again, are the most common symptoms that we see with long-haul COVID, as you can see on the slide, there are a lot of things that we also commonly see. For example, many patients complain of things like headaches, equal to actually respiratory complaints in our patient population. 45% have reported difficulties with their thinking, otherwise known as brain fog. We also hear a lot about sleep issues and mental health symptoms like depression and anxiety. Now, while these are the most common symptoms that we see, there are also some more unique but not rare symptoms that we encounter. So for example, we have many patients that have ringing in their ears, tinnitus. That's new. Some patients complain of prolonged loss of taste and smell, sometimes lasting for several months. There can be hair shedding, otherwise known as telogen effluvium, sometimes starting several months after the infection. We also hear about syncope episodes, sinus discomfort, and most recently, GI symptoms. So the overall takeaway for these two slides is that long-haul COVID really is more than just fatigue and respiratory complaints. It seems like every day we are learning more and more about the types of symptoms that we can see with this condition. A question that I often get is who gets this? What are the risk factors for long haul COVID? And this has been a question for researchers for a very long time. And there has been some progress made in this area. In this past June, a study was published after researchers looked at the electronic health records and survey data from a combined 1.1 million patients. And what you can see here listed at the bottom of the slide are the risk factors they found for long haul COVID. Things like advanced age, female gender, white ethnicity, poor pre-infection health, and elevated BMI and asthma. And some of these would really seem to make sense. One common thought amongst providers and the public is that it's only individuals who get really severe acute infections that get long haul COVID. And this is partially true. There was a study published in August of 2022 where researchers looked at 732 patients and to see if there was any relationship with the type of infection a person had and their chances of getting long haul COVID. And what they found was that individuals who had a severe infection had a higher odds of getting long haul COVID, 3.62 versus 3.01 for those who had a moderate infection. So that seems to be pretty consistent with the common thoughts out there. But what's really important to notice from the study as well is that 56% of the patients in the study reported a mild or asymptomatic acute infection. So in other words, you don't have to have an acute severe infection in order to get long haul COVID. And this is what we also have seen in our clinic. 75% of the patients in our CARB clinic did not have a severe acute infection. Most were mild to moderate, even some were asymptomatic. In our own patient population, we also did not see any kind of relationship with pre-existing respiratory or cardiac issues, pre-existing depression or anxiety, or pre-existing chronic fatigue or fibromyalgia, two conditions that are very similar to long haul COVID. It's also worth noting that the average age for our patient population is younger than what we would typically associate with more severe acute infections. The average age was 45.4. And like the previous slide, the majority of our patients were actually female at 68%. We thought this was a fluke initially, but this is something that's been repeated in other research studies quite frequently. Another question that I often get is how often will this occur? And research has been trying to figure this one out for a long time. The most recent estimates actually come from the CDC, and they look back at millions and millions of records of patients who had long haul COVID. And what they found was that approximately 1 in 5 adults under the age of 65 can be expected to develop long haul COVID. So that's 20%. Things get worse as you get older. If you're older than the age of 65, then your chances go up to 1 in 4 or 25%. And this has been pretty consistent with what we have also been seeing in our own research studies at Mayo Clinic. We've estimated anywhere between 10 to 20%. As for prognosis, as I mentioned at the very beginning here, unfortunately, we have been dealing with this condition now for about 2.5 years, and we have data to see how patients are doing over the long haul, no pun intended. And the short answer is they're not doing very well. In a study that looked at 1,300 participants with long haul COVID to see how they fared over 12 months, about 50% of patients reported still experiencing at least one symptom at the 12-month mark. In addition, during that time period, the prevalence of anxiety and depression also increased over that time period, which is not too hard to understand for someone suffering ongoing symptoms. So unfortunately, it does seem that the name long haul COVID is appropriate for this condition. Okay, so that's what long haul COVID looks like from what we have seen in our own clinics here at Mayo. And when most people hear about the kinds of symptoms that long haul COVID is associated with, their initial reaction is, that's just not possible. How can a virus cause so many problems across so many different systems? And it's a natural reaction. But believe it or not, this story of a virus causing prolonged issues after the acute stage, this is not a new one. What we are seeing with long haul COVID is actually a sequel. If we go back in history, there's even evidence all the way back at the 1918 Spanish flu that patients who had the flu experienced ongoing fatigue for several months. We've also seen similar findings with Ebola virus outbreaks, as well as with Epstein-Barr virus, the classic cause of mononucleosis, which we all know is associated with fatigue. And more specifically, even in the SARS 2003 outbreak, there are research studies showing that some patients, 60% of patients, were experiencing ongoing fatigue 12 months out after their infection. Why didn't we hear about it then? Well, at that time, it was on much less of a grand scale than what we are seeing now. In addition to that historical precedence, we also now have some evidence that shows that there can be some abnormalities at the cellular level that could explain long-haul COVID. So for example, at the Northwestern Memorial Hospital Neuro-COVID Clinic in Chicago, researchers there took the blood work from 111 of their patients 6 weeks out after their infection and re-exposed that blood to the coronavirus. And they found two things. First, those individuals who had long-haul COVID had a robust interferon gamma response or an inflammatory response, and you can see that in the blue bars there. They also had reduced effectiveness of memory T cells. Those are the cells that are responsible for protective antibodies. Similar information comes from the University of Arkansas. Their researchers looked at the blood work from 67 patients, and what they found was the presence of unique autoantibodies against angiotensin converting enzyme 2. And this was most prevalent in patients that had a severe infection, and they didn't find any such antibodies in their control group that did not have a coronavirus infection. More so, the activity of angiotensin converting enzyme 2 was reduced in patients that had these autoantibodies. And as we are all aware, the coronavirus enters into our cells using ACE2, and ACE2 is a very important enzyme in our body responsible for many crucial activities. In addition to that growing immune system evidence, we also have some evidence that coronavirus can affect the nervous system directly. In a study that was published in November of 2021, researchers looked at 42 patients 90 days after COVID and put them through some very sophisticated brain imaging called a functional MRI. And what they found was abnormal functional connectivity as well as white and gray matter changes present. And then there's neurological research like this, the kind of stuff that keeps me up at night right now. Now, this is just a small study, but in February of 2022, researchers published findings after they looked at the brain tissue from 10 deceased patients after COVID. And what they found was neuropathology that was very similar, if not identical, to that seen in Alzheimer's disease. Things such as tau phosphorylation and oxidative stress. Now, it's too early by far to say that long-haul COVID is going to result in an increase in Alzheimer's, but this just goes to show that we have a lot left to uncover. And the overall takeaway here is that despite all of the strange symptoms that can be associated with long-haul COVID, there is growing evidence of how this may be occurring at a cellular level. And with that, we should not just assume at this point that everything is just due to something like depression, anxiety, or a personality trait. Now, that being said, there also is counter evidence out there that we must consider and consider going forward. For example, in August 2022, there was a study that was published that looked at 171 patients and put them through an in-depth neurological evaluation. And what researchers found was that there was rare objective evidence for any pathology. They also had elevated levels of somatization amongst the patient population. These findings were also noted to be associated with pre-existing psychiatric conditions. So yes, the evidence out there is still mixed, but we must keep an open mind about both sides of the argument. Okay, so now that we've gone through the pathology here a little bit, talked about the symptoms, let's talk about treatment. Now, I want to preface this section by noting that there is no gold standard for treatment at this point. What we do at Mayo Clinic is due to the combined expertise of multiple different medical specialists, as well as drawing on our experience of treating work-related conditions. But again, somewhere else may do something differently at this point. Looking at the overall treatment process, we divide long-haul COVID into three distinct phases. First, the post-acute phase, which is between 0 to 4 weeks after infection. Then there's the early long-haul COVID or post-COVID syndrome phase between 5 and 12 weeks. After that comes the true long-haul COVID phase lasting more than 12 weeks out from infection. And my program, the CARP program, focuses in this early phase between 5 and 12 weeks. If we zoom into that area, this is what our overall treatment paradigm looks like. It's 4 distinct steps. Step number 1 is an in-depth interview with psychosocial support. Step number 2 is an evaluation for serious and/or common medical conditions. Step number 3 is a targeted evaluation, focusing primarily in the areas of cardiology, pulmonology, psychiatry, and neurology. And then after all of that comes rehabilitation. So I'm going to go through each one of these steps here in more detail. Step number 1, arguably one of the most important. If there is something that I have found universally present amongst all patients of long-haul COVID, it's that they feel abandoned. It's really unfortunately easy to see how this may have occurred. Long-haul COVID is such a new condition that many providers and patients, family members, they're just not familiar with this. And so when patients experience these prolonged symptoms, they often get told some very unhelpful things, like this is all in your head, you're just anxious or depressed, and probably the most troublesome, you just need to get with the program and toughen it up like everybody else. Because of this, patients with long-haul COVID, they often turn in on themselves. They start to ask, what is wrong with me that led me to have this kind of recovery? Am I just weaker than everybody else? What's wrong with me? This leads to guilt, self-doubt, clinical depression, anxiety, PTSD, and frankly, some individuals just start questioning their sanity. So because of all of this, one of the first things and most important things that we do for patients is that we listen to them. We let them tell their story without bias and with empathy. And after they're done telling us their story, we let them know that their symptoms are consistent with the symptoms that we have seen in hundreds of other patients with this new and evolving condition, and that we're going to help them the best we can getting through all of this. This validation for patients can be extremely therapeutic. And frankly, I think they're looking for this validation first before they're looking to actually get better. Many patients out there understand that this is a very new condition and that there is going to be no quick fix for this. But despite that, validating their symptoms can start the recovery process from step 1. Step number 2 is the evaluation for anything else that could be going on. And this is very important because we do have research findings that indicate that people in the first few weeks after an acute infection can have some very severe outcomes like pulmonary embolisms, heart inflammation. There's even some reports of death in the first few weeks after hospital discharge. So because of this, we do a very in-depth evaluation, usually lasting about an hour for every patient. Now, I know I'm preaching to the choir here about the benefits of an in-depth interview, but I just wanted to highlight in this slide some things that we pay particular attention to. So first, we always ask about post-exertional malaise, the state of a patient doing some activity and then having prolonged fatigue afterwards. We consider that a hallmark feature of long-haul COVID. We also spend a lot of time talking about function, both in regards to current ADLs, IEDLs, exercise, as well as how a person was doing before their infection. Having a good understanding of how people are doing before their infection helps us set a more realistic baseline for recovery. We also query about sleep, of course, work, mood, and anxiety. And you can see there's a couple of scales that we use routinely to help with patients. As for initial diagnostics, these tend to be pretty limited. You can see here what we typically do. And from those, you can kind of tell the things that we are looking for, anemia, ongoing infection, thyroid issues, and so forth. If this seems like a very limited initial panel, that is by design. When we first started working with patients with this condition, we really didn't have any idea what could be causing all of their symptoms. So we did every test under the sun that we thought would be remotely helpful, echocardiograms, brain MRIs, and so forth. And when we went back to see how helpful those tests were, we found that they weren't very helpful at all. So for example, of the 35 chest x-rays that we did, only one was abnormal, and it was barely abnormal. Same for echocardiograms and pulmonary function tests. In fact, the only thing that was routinely abnormal was our test for autonomic dysfunction, otherwise known as autonomic reflex test. We'll talk a little bit more about that soon. But the overall takeaway here from this is that less is more when it comes to diagnostic tests for patients with long-haul COVID. Clinicians should only test whenever there's a clinical indication. This is especially true for this condition because right now there's still very nebulous insurance coverage of this condition. And the last thing we want to do for patients who've been out of work for 2 months in stress is to give them a multi-$1,000 medical bill. Now, I do want to highlight that there has been some progress made in the area of diagnostics. So for example, in June 2022, researchers out of Brazil published a study after they looked at 317 patients with long-haul COVID to see if there was any kind of difference in the cytokine profiles of patients with long-haul COVID versus those that recovered normally. And what you can see here is that the long haul COVID group had an increase in interleukin 17 and interleukin 2, which is an entirely different profile compared to the normal group, quote unquote. Hopefully, with more research like this, we will get closer to having a diagnostic test for this condition. But right now, that still remains something we don't have. All right, step number 3, targeted evaluations. We see a few conditions associated with long haul COVID, and these conditions tend to fall into these 4 buckets that you see here. The reason we call this a targeted evaluation is that, kind of like with the initial diagnostics, we won't go into these buckets unless we have a reason to, based on the patient's presentation. So yes, a lot of people with long haul COVID have shortness of breath, but not everybody. And so if someone doesn't have shortness of breath, we're not going to go into the pulmonary bucket and do things like a chest CT or pulmonary function test just because. So let's look at these buckets a little bit more closely. First up, cardiovascular bucket here. Cardiovascular symptoms are quite common in long haul COVID. Almost 20% report ongoing chest pain or pressure 60 days after their infection. About 5% of patients report palpitations. Some patients have also demonstrated ongoing myocardial injury, evidenced by elevated troponins, as well as myocardial inflammation seen on cardiac MRI. So with all of that, we pay close attention and query patients about any type of cardiac symptoms. If the patient does have cardiac symptoms, the first things that we typically will do are an echocardiogram and a cardiac MRI. We have found that the cardiac MRI is particularly helpful for identifying any form of heart inflammation. If we need to get some more information about how the heart is functioning under stress and exercise, we can do things like a cardiopulmonary exercise test. The only thing you have to be cautious about that is remember that patients with this condition can get quite tired after minimal activity. So a CPAT can cause them to have a flare of their symptoms for several days. If you go to the research and you read about cardiovascular and complications of long haul COVID, you're going to find all sorts of different diagnoses. But in reality, what we typically see is either myocarditis or new hypertension. We've had a few cases of pericarditis as well. Fortunately, we have not seen the more severe things such as, myocardial infarction or an aneurysm or something like that. Those remain quite rare. Next bucket, pulmonary. What's important to remember about the shortness of breath after a coronavirus infection is that it can last for several months, even without being associated with all of the other long-haul COVID symptoms. So someone can have shortness of breath without brain fog, fatigue, and that's normal. So typically, because of that, we will delay evaluation of any kind of pulmonary issues until about 12 weeks have passed since the acute infection start. So if someone is still having cough and shortness of breath 3.5 months out afterwards, that's when we will do a chest CT and a pulmonary function test. We will go down that road earlier if a person has pre-existing lung disease like COPD, or they seem to be getting worse. What we typically will see on the chest CT and a pulmonary function test is a decrease in DLCO, as well as maybe some indications of pulmonary fibrosis. And if someone is having ongoing shortness of breath, we actually will start treatment before we do some of these evaluations. Treatment typically using inhalers, both standard inhalers as well as steroid inhalers, and also getting the patient involved in pulmonary rehab. We found that to be quite helpful. Bucket number 3, psychiatry. I've already mentioned some of the importance of psychosocial support here. And only 2 things to take away from this slide. First, we will sometimes use medications to help patients who are suffering from more severe psychiatric symptoms such as mood, depression, and anxiety. It's important to remember that if you use some of these medications, that could pose a safety concern when it comes to work. I've looped in here also sleep. We've seen a lot of individuals have sleep problems with long haul COVID. And in my opinion, this is often the lowest hanging fruit to help patients with their recovery. Sometimes patients will sleep too much, sometimes they'll sleep too little. And when it comes to helping with sleep, we treat it just like any other individual that has problems with their sleep. We start first with sleep hygiene. Many patients have an altered circadian rhythm because of napping during the acute infection. And one thing that can be helpful for resetting that is melatonin every night. If someone is having difficulties with snoring that may be new, we'll do an overnight sleep study and start them on CPAP if needed. Now, for whatever reason, we've actually found quite a few individuals have undiagnosed obstructive sleep apnea after long haul COVID. And I don't know, is it because we're checking or is it because something actually changed because of the infection to give them this? But in any case, if someone does have undiagnosed obstructive sleep apnea and we treat them with CPAP, they report a world of difference. And again, here I note that if someone is not sleeping well and they're fatigued during the day, falling asleep behind the wheel, that also could pose a safety concern for work. All right, moving on to the biggest bucket that we deal with, neurology. The more that I get to work with long haul COVID, the more this does seem like a neurological condition in addition to a respiratory condition. So first up, we see some general neurology symptoms. Many patients report headaches, and we treat this using our usual headache tactics like optimizing sleep, good appetite and hydration, sometimes medications, or a headache consult. We also hear a lot about tremor, and this can be a tremor like we would figure standard tremor that you can see in the hands and things like that. But some people will also report feeling what's called an internal tremor or an internal buzzing sensation. Either way, we have found that using propranolol can be helpful for alleviating these symptoms. Now, for more specific things related to long haul COVID, first up, taste and smell difficulties. Well, we all know that taste and smell problems can happen during the acute infection, but some individuals, about a third, will have ongoing problems lasting several weeks to several months after the acute infection. The good news is that most people get better with time alone. Only about 5% still report having symptoms lasting at the 6-month mark. But that can be a pretty miserable 6 months. So patients are often looking for ways to get better faster. And the only thing that we have found to be helpful in the research as well as anecdotally is olfactory retraining. Now, what is olfactory retraining? It's an actual process that a patient needs to follow. First, it involves smelling 4 unique odors: rose, eucalyptus, lemon, and clove. The patient has to smell each one of those for 20 seconds, twice a day, morning and bed. And they have to do this pretty consistently for about 3 months. And what we have found with that is that patients will get back their taste and smell faster. Interestingly, there's also been some recent research indicating that olfactory retraining may even be able to help with some of the brain fog that we see with long haul COVID, perhaps due to some of the neuroplasticity involved in the brain. All right. The next thing that we deal a lot with in the neurological realm is dysautonomia. Now, to grossly oversimplify, the autonomic nervous system is the part of the nervous system that takes care of everything that we normally don't pay attention to, like breathing or sweating or our GI system moving or paying our taxes. Now, if something is wrong with this system, then there can be a lot of unique symptoms, some of which you see here: brain fog, tachycardia, pain, shortness of breath. Now, if those all look familiar, that's not just a coincidence. Autonomic dysfunction was seen after the previous coronavirus outbreaks, SARS and MERS. POTS, or postural tachycardia syndrome, that has nothing to do with marijuana, it's a form of dysautonomia that has been shown to be preceded by a viral illness in 21 to 40% of patients. And we already have case reports of POTS occurring in patients recovering from COVID-19. So we think that dysautonomia is responsible for a lot of the symptoms patients with long haul COVID have. Because of that, we focus on the dysautonomia quite a bit at Mayo. And that focus starts first with doing a test for dysautonomia known as the autonomic reflex test. There's typically 2 parts to that test. First is something called a tilt table, which is exactly what it sounds like. We place a patient on the table and change the incline while measuring blood pressure, heart rate, and heart rate variability. We also do something called a QSART test, which measures sweat output on a piece of skin that's still attached to the patient, to see if there's any troubles with sweating. Now, some additional things that we can do are like the Compass 31 survey, which is a nice inventory of autonomic symptoms, an epidermal nerve fiber biopsy looking for small fiber neuropathy changes, and a thermoregulatory sweat test. Just on a side note, if you're not familiar with the thermoregulatory sweat test, it's also affectionately called the Smurf test. What we do with this test is that we ask the patients to disrobe and we cover them with a powder that will change color depending on where they sweat. Then we put them into a room and crank up the heat for about 30 minutes. And then we come in with a camera and take a picture of them. Patients just love this test. It's a good time for selfies. And as you can see here, if there's any dysautonomia, there can be some sweating abnormalities that you see here in these diagrams. Now, fortunately, the mainstay of treatment for dysautonomia is conservative treatment, things like hydration, adequate salt intake, and compression garments. Now, I know most people out there kind of roll their eyes when it comes to conservative treatments, but this is really crucially important for dysautonomia. So crucial that we actually have a POTS virtual education clinic at Mayo that we will enroll patients in to meet with a trainer one-on-one to understand how to do these conservative measures effectively. If we need to get more treatment on board, there are other things that we can do, such as beta blockers, alpha-2 agonists, mineral corticosteroids, and so forth. But it's definitely not the majority of patients that require this. All right, just to recap, we did psychosocial support. We looked for anything else that could be going on that caused the patient's symptoms. We addressed some of the usual things that come with long-haul COVID, like shortness of breath and dysautonomia. With all of that, hopefully the patient is feeling better, and that will make them more able to participate in rehabilitation effectively. And why is this important? Well, we know that after previous SARS and MERS infections, patients had decreased exercise capacity after their infections. Almost 80% reported a decrease in their VO2 max. We've also seen similar things with COVID-19, where 41% of patients have reported reduced exercise capacity. So what do patients do about this when they feel deconditioned and unable to exercise? They do what any of us would do. They lace up their sneakers, they turn on the training montage music from an 80s film, they hit the gym, and they try to grit their teeth to get through this. No pain, no gain. And why is this? Well, probably because of the pandemic. Patients with COVID-19 get sick of being sick. They are just tired of being in isolation, tired of having to deal with this. And so when they get the green light to leave their homes, what do they try to do? They try to overdo it. They hit the gym, they work out hard, they go to work extra, they take on extra projects, they try to repaint their house. And they feel great initially because they're finally doing some activity after being in bed for 5 days. Unfortunately, this leads to a flare of their symptoms typically. They get fatigue that lasts for hours or days. That causes them to rest excessively. And during that time period, they get further deconditioned and have more mental stress. And because of that, though, they're resting, they're ready to go again. So they try again, and then this circle repeats. And this is quite devastating for patients with long-haul COVID because, again, remember that patients with long-haul COVID have post-exertional malaise. Now, if the idea of having fatigue lasting several days or hours after activity sounds odd, just know that this is something that's been reported in 30% of patients with chronic fatigue and fibromyalgia. And these are periods, this post-exertional malaise are periods where patients are not just tired. You think that they actually are experiencing oxidative and inflammatory stress on their body, leading to prolongation of the recovery process. To support this thought, studies that have looked at treatment methods for chronic fatigue and fibromyalgia have found things like graded exercise, or leveling up exercise in an attempt to push a patient through, can result in a negative effect in almost 75% of patients. So the overall takeaway point for all of this is that rehabilitation for long-haul COVID does not equal exercise. Instead, what we practice here at Mayo is something called an adaptive pace therapy, otherwise known as low and slow. In this kind of therapy, we use a patient's home activities in addition to the normal rehab activities, like doing free weights and Pilates and things like that. But we use also the home activities to help as part of the rehab process. So doing the dishes, doing the laundry, going up a flight of stairs, that all counts as part of the rehab process. It's also a paradigm of not simply stopping when it hurts. Remember that many patients with long-haul COVID, they're often resting in between bouts of activity. Because of this, they have a lot of pent-up energy and they're able to push themselves. It's only afterwards when they realize that they push themselves too hard. This is also a very individualized approach. We'll use a patient's unique experiences to help guide their titration. So for example, if someone says, well, I can walk the dog for 10 minutes and not have post-exertional malaise, we'll start them there at 10 minutes and then gradually increase over time, maybe 13 minutes the next week. Now, when I say we do this, we rely very heavily on our physical and occupational therapy colleagues, particularly our work rehab group, as they are very familiar with helping patients navigate through a lot of psychosocial factors affecting their recovery. Now, of course, As we all know, anytime someone mentions therapy, the question is there any proof that this actually works? Unfortunately, yes, we do have some proof. So for example, there was a study published recently that looked at 85 patients with severe COVID to see how they did after going through about 30 to 40 days of rehab. And what they found were significant improvements, some of which you can see here. For example, the number of individuals that required supplemental O2 went from 83.5% all the way down to 8.2%. And these are the kind of findings that we see in our own patient populations. All right, so that is the treatment program in a broad overview. Now, you may be wondering, well, what about all of those things that I've heard about, say, on Twitter or Facebook, or my patients ask me about, like ivermectin or monoclonal antibodies or Paxlovid and such? Well, I can tell you that we've spent a lot of time amongst my colleagues trying to find that magic bullet to treat this condition. And unfortunately, we don't have any evidence that these work yet. I'm not saying that they don't work, but we just need some better research studies in order to justify using some of these treatments. Most of the evidence that's out there right now is anecdotal. And I can tell you that for every patient that you may have heard where they got better, saying using ivermectin, I've heard of a patient story where they got worse. Now, that being said, we are making some progress. And I just highlight a recent study here involving naltrexone. Now, you may be scratching your head here. Naltrexone is an opioid antagonist. It's also known as Vivitrol. We use it for people who have overdosed on opioids. I don't think long haul COVID has anything to do with opioid overdose, but what we have found with using low dose naltrexone is that it works on the immune system. And there have been some studies showing effectiveness of things like Crohn's disease, fibromyalgia, and multiple sclerosis. A recent study in Ireland looked at 36 patients with long haul COVID, and they treated them with about 1 to 3 milligrams over 3 months. And what they found was statistical improvement in function, energy, sleep, concentration, and pain. Now, this is not a perfect study by any stretch of the imagination. For example, there's no control group, the participants weren't blinded, and it's a small population. But it's a drop in the bucket for hopefully heading in the right direction of getting some actual treatment options other than rehab for these patients. Okay, so we've gone over the symptoms, we've gone over the biological reasons why patients may be experiencing this, and the treatment of long haul COVID. And this is typically where the conversation about this condition ends. But that's unfortunate because symptoms and treatment, that really is only the tip of the iceberg. The often overlooked aspect of long haul COVID is how this condition also affects a person's ability to live their lives at home and especially at work. So let's get the full picture and finish up here by exploring the challenges that long haul COVID poses for workers and employers. First up, the greatest challenge that long haul COVID presents for work are the functional declines that patients experience with this condition. At the time of presentation, 34% of our patients reported troubles with some of the most basic activities of life. That would be things like putting on your clothes in the morning, taking a shower, or eating but not cooking. 82% reported difficulties with the more routine things like driving, grocery shopping, household chores, and of course, work. Now, at the time of presentation, 63% of our patients were back at work in some form. Now, that sounds kind of promising, but it's also important to note that the average time between infection and presentation at Mayo Clinic for long haul COVID was 3 months. So another way to look at this is that 3 months after an acute infection start, only a little bit more than half of patients were back at their work. In addition, of those patients that were back, only about half were back to their baseline work. The rest required some form of accommodation, like reduced work hours or lifting restrictions. To make matters worse, this functional decline, it doesn't get better with time alone. In a study in New York City that looked at 530 patients of long haul COVID after 12 months, what they found was that about 40% of patients reported worsened health, 44% reported persistent symptoms, and almost 40% reported ongoing functional difficulties like lifting a bag of groceries or climbing a flight of stairs. Likewise, the work impact of long COVID doesn't get better either. In a study of patients with long haul COVID to see how they were doing 7 months out after their infections start, the percentage of individuals who were fully employed went down from 72% to 44%. The number of individuals working reduced hours or who are out of work also increased over time. All right, the next challenge that long COVID presents for work is the S word, safety. I'm going to go back to revisit this slide from the very beginning where I described the most common symptoms that our patients present with in the CARP clinic. I'm going to highlight here again, brain fog at 45%. And I always point this out because of all the symptoms that we have seen associated with long haul COVID, this tends to be the most stressful. And why is that? Well, this is what really causes the most problems at work. So what is brain fog though? Well, it's important to realize that brain fog is not a medical term. If you go to a medical dictionary to try to look this up, you won't find it there. But despite that lack of an official definition, if you stop and ask patients with long haul COVID what they are actually having troubles with, they are remarkably all having the same complaints, which you can see here. The most common thing that we hear about is short-term memory issues. So patients will say something like, well, I went to drive to the store to pick up something, and then when I got there, I couldn't remember why I was at the store. Another common thing that we see are troubles with word finding. Patients will say that they have a word on the tip of their tongue that they just need to get out. They know what it is, but they just can't, which is very frustrating for them, especially when they're trying to perform work activities or explain their condition to their employer or to their medical providers. Multitasking also tends to be impaired. Patients have troubles doing two things at once, even if it's something that they have done for many years at their job. And that's the subjective description. What about objectively? Is there any evidence that this actually is real? Well, fortunately, we are making some progress in this area. Research is starting to trickle out now, and some studies indicate that, yes, there is an objective impairment that comes with brain fog. So for example, in February 2022, researchers published their findings after they put 60 patients through a multidisciplinary assessment, including a full multi-hour neuropsychological battery. And what you can see here is that patients with long haul COVID scored below normal on substantially more domains when compared to the control groups, 8 out of 11 domains versus 1 out of 11 domains. In addition, the percentage of extremely low scores was double in the long haul COVID group compared to the control group. Similar findings were also noted at Mount Sinai, where they've had a long haul COVID clinic for some time. They followed 156 patients over 1 year to see how they were doing. At the end of 1 year, 82% reported ongoing fatigue, 67% reported ongoing brain fog, and most alarmingly, 63% had mild cognitive impairment on the neural qual assessment. Whatever definition of brain fog you choose to rely on, the objective or the subjective, the impact on an individual's work is undeniable. So for example, if you work as a waitress, difficulties with speech, memory, and multitasking will make your job duties, like taking orders from a group of 6 in a loud restaurant, difficult at the best. But there's more to it than that. Brain fog impacts more than just individual job performance. Let's say, for example, you don't work in a restaurant, but instead you work here. I think we can all agree that having troubles with multitasking, short-term memory, and speech in this kind of complex environment will greatly impact safety, both at an individual level and at a public health level. Now, the safety implications of long haul COVID, they're only now something that is becoming a concern. We have a long ways to go in this area. But hopefully by having talks like we're having this today, we'll start making some progress in this area and start protecting workers and the public better from long haul COVID. The next occupational challenge, there are no standards. What do I mean by this? Remember that this is such a new condition that we don't even have an agreed upon name yet. So here at Mayo Clinic, we call it post-COVID syndrome. The public calls it long haul COVID. The NIH calls it post-acute sequelae of SARS-CoV-2, which is awful. Likewise, we also don't have a uniform definition. The most recent definition came out in October of 2021 by the World Health Organization. And you can see the requirements here, but just to summarize, for someone to have long haul COVID, according to WHO, you have to have symptoms longer than 3 months out after your infection, and those symptoms must have been present for at least 2 months. The important nuance here to realize that you don't have to have symptoms the entire time. They also can explain the patient's symptoms by an alternative diagnosis. The CDC has an entirely different definition. First, they call it post-COVID conditions, And they apply that to pretty much anything that lasts more than 4 weeks out after the acute infection starts. So we've got definitions, but they're hardly defining at this point. Likewise, there's no single objective test for diagnosis. We don't have a clear understanding of all the symptoms that we will see in the patients with this condition. We also don't have an appropriate test for assessing cognition, the brain fog reliably, the brain fog that so many people with long-haul COVID report. Why does this all matter? It matters because it's going to be really hard for us to start addressing long-haul COVID, both in general and at work, if we can't really figure out who has long-haul COVID in the first place. Next challenge. This is uncharted territory for employers. When the media discusses work issues of long COVID, they almost always focus on the patient, which is understandable. It is also important to remember that employers are also struggling with figuring out how to deal with this condition amongst their workforce. There has been some progress in this area. In July of 2021, the government recognized long COVID as a protected disability under ADA. Now, I know I'm preaching to the choir here, but just to review, what's a disability? Well, it's a medical condition that substantially limits one or more major life activities. And if someone has a disability, they need reasonable accommodations in the workplace. And we're all used to the idea of reasonable accommodations. Let's take an example, low back pain, very common work-related malady. If someone has low back pain, they may need something like work restrictions and limitations. They possibly may need to do something else at work or a temporary alternative duty. Maybe they'll be involved in job rotations. And there's a general culture of support from coworkers and employers to help patients get back on their feet. But what is a reasonable accommodation for someone with long-haul COVID? If someone says that they get tired and short of breath after minimal activity or an hour of work, they need to take naps 3 times a day, they have a headache, and they have frequent diarrhea, how do we accommodate that person in the workplace to ensure their success? And no, I'm sorry, I don't have an answer to that question yet. All right, for the final challenge that long-haul COVID presents for all of us at work, it's that it's not rare. So just consider these calculations. They'll give you an idea of what we're facing ahead of us. As of this week, there have been roughly 95 million COVID-19 cases in the United States alone. If we conservatively estimate that 10% of patients with COVID will come down with long-haul COVID, that's half of what the CDC has estimated, 10%, then that's 9.5 million post-COVID syndrome cases in the United States alone. Based on our experience and research out there, we estimate that 30% of patients with long-haul COVID are going to experience ongoing functional deficits for several months as part of their long-haul COVID condition. And that's 2.85 million people unable to function normally because of long-haul COVID. And these are not just nameless numbers. This 2.85 million, these are teachers, firefighters, nurses, police officers, and so forth. So long-haul COVID, it's more than just a healthcare challenge. It really is a challenge for our society as a whole and for our economy. And this brings me to my last slide and point for today. Whatever you take away from this talk, just remember that we are at the very beginning of understanding this new condition. And until we have a better idea of what is going on inside the body, we need to be very careful about deciding what is and isn't long-haul COVID. And we need to remember that just because something is unexplainable doesn't mean that it's non-existent. Only by keeping such an open mind can we get the patients the care that they need, can we get people back to their livelihood, and can we change this condition from being a challenge to being cured. And that concludes my presentation today. Here is my contact information. Again, I appreciate the opportunity to speak with you, and I'm happy to answer any questions at this point.